Hello, and how are you? My name is Winnie Barawa. Welcome to another session where we're going to discuss on labor and delivery care of the women with FGM. If you're new here, this is a channel that caters for lectures, lessons, and expert interviews pertaining to healthcare. And in our series, we are focusing on FGM, which is one of the harmful practices in our community. And this is supported by the Girl Generation in collaboration with ACAF and the University of Nairobi, a movement that is focused on ending or abandoning of female genital mutilation in our communities. So we have been flowing in with the journey that is from the beginning, like what is FGM, what are the drivers, the causes, the prevalence cases and statistics, and they've checked on the complications, both long-term, short-term, and also specifically checked on the obstetric complications of women who have undergone FGM. But now we are looking at what can we do, for example, if you come into contact with a woman who is in labor and they have undergone FGM. In the prior video, I've discussed the management you can give for a woman who has FGM and is in the antenatal stage. But now some cases you may find yourself, you've met a woman who is in labor and preparing for delivery and they have undergone FGM. So dwell with me as we explain further on this topic. So first of all, to remind us, we've said that a woman who've undergone type 1, type 2, and type 4 type of FGM may not be at risk of developing female genital mutilation complications during their deliveries. However, we say during antenatal stage that type 3 FGM may actually lead to some complications or may lead to severe complications during delivery. However, there's a good part of it. For a woman who've undergone type 3 FGM but has been taken through de-infibulation, which is the intervention that can be done for a lady or for a woman who's been done infibulation FGM, then that lady is unlikely to have any complication during delivery. So if we are able to confirm these facts before delivery, then we can rule out the lady that she's off risk and she may not need to be put as a high risk mother. Note that at any given time, don't assume the mother has been on care. However, confirm that possibly this could be the first time that woman is coming into contact with the healthcare provider for that particular pregnancy. So it's good to explore the chances that the woman is a first-timer contact or is the first contact in terms of care and intervention in that particular pregnancy. So explore in detail the history, explore in detail the physical examination, explore in detail the clinical evaluation and intervention so that you can be able to understand her and eliminate her from any risk related to the FGM that was done to her. So in the initial evaluation of the women in labor, we have explained that you need to do deep history or we need to take exhaustive history. So find out about her FGM status. Take history, take deeper, keen interest in her previous pregnancies. Ask whether if she has had any related complications in the previous pregnancies, if this is not her first pregnancy. Generally, we want to explore her status in regard to FGM or in regard to experience with this practice. So don't also make an assumption that she's not aware about it. Maybe she did it voluntarily with consent. So you may want to welcome her into understanding the risks and the possible complications that may come out of it. So you want to find out all these facts. What type of FGM has she undergone? Is she aware about it? What is her level of knowledge around that? Does she understand the change of her anatomy? And does she understand the reproductive risks that are related to this? And if she understands, then have she experienced any of the complications in her previous pregnancies? So with the initial evaluation for the woman who is in labor, now we have said you assess FGM status. You want to confirm the type, what type of FGM did she go through, and then are there any presence of complications, and what is the elasticity status of the perineal tissues. So in the previous video, we say that during the physical exam, we need to do a digital checkup to just see if the fingers can fit. That is the middle and the index finger, if they can fit in within the vaginal opening. If that is possible, then we can rule out that there is adequacy and the lady may not be at risk of much complications. But now, in the case where you do the digital check and you have confirmed that there's risk of further complications, then you may actually try to prepare for early interventions to prevent these complications. One of it could be de-infibulation, or in other cases, you may opt for interventions like cesarean sections, not only to save the mother, but also to prevent complications like obstructed labor, prolonged labor, or complications for the neonate such as birth asphyxias. So any presence of complications, we intervene early enough. So how do we assess for the elasticity of the perineal tissues? So we are advised that slowly and carefully introduce first one finger into the vagina to measure the tightness of the intraosseous. And then if it allows one finger, then you try to move that finger up and down. So you get the finger up and you get the finger down, and then you move it left to right. If there's space for a second finger, try to widen the two fingers and check for any resistance. Now, this copies like the procedure of vaginal examination during the labor and dilations. Now, with this, you're able to tell if there's adequacy of the opening to accommodate a child during the second stage. So you want to check the elasticity of the perineal tissues and if they can accommodate the child during the period when the mother has to push. So you're being advised again if the vaginal intraosseous is tight. So explain to the woman that you may have to do an episiotomy during the delivery stage or during the stage when you need to allow the child to come out. However, if the woman is with type 3 type of FGM and they have not gone through the infibulation before, then you can discuss that they will need to do the infibulation at the earliest possible opportunities, and also if the lady allows for consent. So these are possible outcomes that you can get when you evaluate the woman who is already in labor. You have assessed her FGM status and you've been able to tell the type of FGM. And we have repeated before that if she's type 1, type 2, or type 4, you don't need to worry about much of the complications. But if she has gone through type 3 and there was no any defibrillation done, then you should prepare for complications and intervene early enough. However, check through and confirm the elasticity of the perineal tissues by doing the digital checkup, by slowly introducing the first finger into the vagina to measure the tightness by moving that finger up and down, left to right. And if there's a space for a second finger, you can try get it in and widen these two fingers to check for the resistance and the elasticity status. But unfortunately, if you discover that the woman has a tight intraosseous, then you may opt to explain to her why an episiotomy will be needed during the delivery process. But now there's the case of type 3 FGM, where in this case the opening is sutured and the opening is very small, so it may not allow even for um, allowing the access with fingers or the two digits that you want to check in with. So in this case, you need to discuss for the need for de-infibulation. You may want to discuss with the woman for the need of other interventions like cesarean section in case there's no other options. So discuss it at the earliest opportunity and also obtain consent from the woman. Now, the question that follows next is, we've assessed the lady, we have seen the progress of labor, we have seen the possible outcomes. How do we monitor labor? So monitoring labor in women with FGM is just the same as those without the FGM. You'll need to open up um, your patograph, get to fill the details as required there from the biodata, from the membranes, from the time when the labor began, to the descent and the strength of the frequency and strength of the contraction. Basically, you manage using the patograph. This is to allow comprehensive follow-up, comprehensive monitoring, and to rule out any developmental complications or deviations from the woman. However, you need to put in mind that vaginal examination may be quite difficult for the women who have a tight vaginal opening or those who have undergone type 3 FGM. So while we monitor the progress of labor, you need to remember that and understand that you may not do the vaginal examination as frequently or as similar to the normal woman or the woman who have not gone through FGM. And this marks us to the end of our class. Please remember to like, comment, share, and subscribe to our channel. Click on the bell because this is going to allow us to inform you when we post our next video. You'll be the first one to be notified. So thank you for staying with me to the end, and see you in our next class. Bye.